Thank you, Sarah, and I'll get started and be followed then in sequence by my good friend, Dr. Applegate. Thanks for inviting us here. If you came here because you think we have all the answers, you will be terribly disappointed at the end of the morning. But what we have been able to do is assemble partners, work with others who share common goals, and been able to accomplish a few things. And so in a true kind of case study format, we'll walk through some of the accomplishments first and then get into some conversation about how'd you do that and what were the barriers and other problems that we might have run into. So now the payment reform is the major emphasis that we're going to have here. But I just want to reinforce that you can't have payment reform unless you have healthcare delivery system reform, right? They have to go hand in glove. And so I'm going to focus a lot more on the healthcare delivery system reform part of this equation, and then I'll let my partner talk about some components because of her Medicaid background in the payment reform component that we're going to face. So in good times, this is what Mary's doing most of the time, is taking care of babies, and has done it for a lot of years and done a tremendous job. Well respected in her community, well loved. They hated when she came to Medicaid, and I loved it because I needed somebody that had a heart for the population we're trying to serve, and I knew that she had demonstrated that. On my side of the equation, I come from a regulatory agency, so when I go in and tell people I'm here to help you, they usually get really frightened by the things that we do. So I have to show the softer, gentler side every once in a while, just to make sure that I calm down the anxiety in the room. And of course, we always start young with our training that we do, so I learned that years ago. Well, the reason there's some interest, I think, in what, from my perspective, has happened in Ohio is that an unlikely leadership had to happen in the state to make transformation of health care occur, and that was public health, right? So I came into my position as the director of health with a very strong direction from our governor that I was to take the patient-centered medical model of care, a coordinated primary care model, and take it statewide. Well, you can imagine when I went into my position in public health that they were a little bit surprised and not quite ready for that, because public health had its usual turf areas that it worked with, and clinical medicine had its usual areas that it focused on, and the two didn't usually work very closely together. So I had a little bit of work to do to move that forward. Fortunately, in Ohio, we already had some regional collaboratives going on in Cincinnati, Columbus, and Cleveland areas, and they were built around health transformation. Fortunately, in Cincinnati and Cleveland, they also had a background in aligning forces for quality work. So they had been working for a number of years in the community with multiple partners, trying to move their whole region forward in quality of care that they deliver. So that worked out well for me and predicted well for the future. Our governor, when he came in January of 2011, Governor Kasich, made his first executive order that he proclaimed to be the development of the Office of Health Transformation. That was a huge, huge effort because prior to that time, our various agencies, Medicaid, health, aging, mental health, and others, had worked quite independently. And there was not a lot of collaboration between them. We were aware of each other, but didn't have a lot of interface. This brought us all together under a single leadership, Greg Moody, and that, I think, created the nice atmosphere we were looking for to be able to work together and come with joint recommendations and decisions that we made. My PCMH directive came out when I came in February, and the next 5 months, besides going through a biennial budget process, is the Office of Health Transformation created their innovation framework, and this is their plan for the future. And what Greg Moody designed with all of us engaged was a three-part effort, and that was to modernize Medicaid first. That's about a third of our budget, so kind of an important issue. At the time, we were $8 billion in deficit when we were doing budget planning, and in our state's rainy day fund, we had 89 cents. So we didn't have a lot to work with, and we thought we'd better start tightening the belt where we can. So modernizing Medicaid was a high priority in the beginning. Streamlining health and human services by helping us operate more efficiently across agencies was extremely important, and that in that process, Medicaid became a separate department. Instead of being under another department, which was Jobs and Family Services, they became independent. And then ultimately, though, the goal, and this was setting us up to design a way that we could push payment for value as a model of payment reform. So this all had a sequence to it that made perfect sense. With that, and as I traveled around the state of Ohio and worked with different partners who really wanted to be engaged with us, we decided that probably we needed some method to allow people to exchange information on a regular basis. That's when we created the Ohio Patient-Centered Primary Care Collaborative, happened in November of 2011. That was a forum by which all interested parties who wanted to be engaged in discussion about the variety of different changes that have to happen could come together from around the state. This has about 850 members right now, and you can be a member if you want to. So it's open to the public, it's free, and easy to sign up for, and I'll tell you later about how to do that. Then, of course, IOM came up with this wonderful report, which regenerated, I think, our interest, because I felt that this was where we should be going. I felt my whole life was moving in this direction, and then to see this integration effort start happening fit perfectly with where we were evolving as an organization. If you look then at our, I'm sorry about the acronym OPC, PCC, I did put that name out there, I'm sorry, but it does state what we're exactly doing. This organization, for us, created the venue now for moving forward with the various partners around the state in a collaborative way. So it had the payers at the table, we had patient advocates and patients that engaged with this, we had the plans that were all there with us, the providers were all there, the large healthcare delivery systems all participated in this and came together on a regular basis as we convened them to have discussions around how we would move forward. So I had a job to do moving around the state of Ohio, and that was to make sure I ran public health, but also that I expressed the need to start the integration of public health and primary care. When I set our priorities for improved health for the state of Ohio, I made sure that I put patient-centered medical home expansion as one of our 4 major priorities. The others are traditional, and everyone in public health will say that makes sense to us. This was something new and something very different for our public health leadership to be engaged with, but it made all the difference because this was built into every talk I did, and I did multiples a week to a lot of different organizations where I started having them understand how we need to all work together if we're going to get at improved total health for the population we serve. Well, in July, and these should both be 2012, by the way, July of 2012, I finally got funding for the Ohio Patient-Centered Medical Home Education Pilot Project. So this is a great story for you guys who say it's kind of important to have great ideas and it's fun to have people who get it, but it's also important sometimes just to be persistent. And in this one, I started this project in 2009 and co-wrote House Bill 198 with a number of sponsoring legislators. We spent a year and a half going through 11 revisions getting this through all the various interest groups that were involved with this. So stakeholder meetings were a regular part of my life during that time. This was signed into law in June of 2010, but, and it was totally supported by both sides in the House and the Senate, 100% vote, and everyone wanted to sponsor this. And the reason was it was a great idea. That was to move this new model of care forward. It also included scholarships for medical students and nursing students, APNs, who were going into primary care, and it also included curriculum reform in the various schools of training. So it was a comprehensive bill, and so everyone thought it was a great idea. The problem was, you might remember, we were in this huge deficit budget, and so it went through unfunded, so, it's the best of times and the worst of times. Great support, no funding. So part of the reason I was interested in becoming part of the leadership at the state level was to see if I couldn't change that. And again, partnering with Medicaid, we were able to determine ways to get this funded to begin this project of training 44 practices in the 4 parts of the state of Ohio that weren't heavily engaged already in regional collaboratives, so they would catch up, so to speak, with the rest of the state. And that's rural Southeast Ohio, Northeast Ohio, central Northeast Ohio, where it's a little bit south of Cleveland area, the Akron-Canton area, and then also the Dayton area north of Cincinnati. So those areas were targeted, and funds went to practices that were selected to do advanced training. But here's the key, and the reason it's called an education pilot project is those had to all be teaching practices. So we didn't just transform anybody. We transformed people who agreed to become a part of the teaching faculty of nursing schools, medical schools, and other schools, because I didn't want to just train them. I wanted to train future generations who would learn in those sites. And that was kind of why it was so complicated, because I had to put all those pieces together. The legislators were great friends to work through this. They got it immediately, and thanks to Medicaid funding, we were able to pull that forward. Well, with all this collaborative work going on, we were successful, as was mentioned, in getting one of the 7 Comprehensive Primary Care Initiative Awards down in Southwest Ohio, the Cincinnati and Northern Kentucky area, because they'd been working so long in a health collaborative there, and their insurers got it. Because you remember, the insurers had to apply for this grant, not the providers, not the state. And the insurers said, we're ready to participate collectively in paying for care coordination, paying for outcomes, paying for value. And that project brought 9 insurers together who are working collaboratively, which is moderately shocking, at least in the state of Ohio. Then the governor saw all this going on and had been devising plans how we're going to expand PCMH, how we were modernizing Medicaid, and in the process saw the insurers coming to the table, so said, it's time for us to put together the Governor's Advisory Council on Healthcare Payment Reform. And in January of 2013, he brought together the 5 major insurers that covered 80% of the population in the state of Ohio, but not just them alone. He brought together all the large healthcare delivery system leaders. He brought together many of the medical associations to the table. Patient advocates and patients were in the room, and blended, and so we're all in the governor's cabinet room. And so the cabinet room's got 25 chairs. We had like 5 people deep behind every person who was in the room. They wanted to know what the heck was going on. And what he did and what he proposed was that these insurers would get behind payment for value. And we used Catalyst for Payment Reform principles, and they bought in and committed to following those principles moving forward as we devised a new way to pay for care in the state of Ohio. Since that time, they've had a number of meetings where they've built on that, but that helped us lead into our state innovation model activities to put together a planning grant that we knew would include the payers in that in a way that they couldn't say they'd be included in the past. Thankfully, in January 2014, we had Medicaid extension in Ohio, so we were allowed and had support for that. This is responding and listening to the public. There was so much support for this. It was unbelievable, but you know, we're very much a Republican organization in Ohio. And so this went against what some of the leadership would have naturally been inclined to do. But fortunately, again, and this is where all those stakeholders around the state came together, they put the proper pressure and put the proper emphasis on what we were trying to do, which is what's best for the people living in Ohio, what's going to help population health the most, not what's going to serve our political interests. So the governor was able to get away from what otherwise would have been probably a natural tendency to follow political channels, and made a very difficult but the right decision, we very much feel. With all that activity, we were redesigning our efforts to transform healthcare delivery and payment in Ohio through the SIM planning process, and then we're able in December to successfully receive the SIM testing grant, $75 million, the second largest testing grant that went out in this last round. So a lot of things have moved in a good direction. This is a very high level view, and we can probably get into detail later if we'd like to, but on my side of the equation, which was about changing the way we deliver care in our practices, we were able to make good progress in practices being able to achieve patient-centered medical home recognition. And some states do or don't use these various agencies to produce the recognition as a patient-centered medical home. We chose not to duplicate the process by putting together a state-run way of recognizing PCMHs, but this was a good indicator that we were having at least some impact. And now I guarantee these are process measures, and PCMH to me is just a step in a direction. So we're on a journey, I guarantee you folks. We are not anywhere near there. But at least we have a foundation we're starting to build that we can hopefully continue to increase accountability to clinicians, better coordination of care, and then we've got something to pay for that's different than we had before. So as I said to a number of people who asked me, don't you need more primary care? And I said, not really. I need enhanced, advanced, modernized primary care clinicians in practice. I don't need what we've had, because we're not doing well in Ohio. I mean, my burning platform is, you know, we were 37th best state according to state health rankings. That's not something I'm particularly proud of, and I've got 7 huge academic medical centers surrounding me at all times. So how can that happen is what we're trying to get at, and how do we change it is the important challenge that we have now. So one important thing I learned as I started out at public health was that I was going to try to do something they weren't used to doing. And so I had to be sure that they understood why we were doing this, what I was trying to achieve, and why it made any difference to them and they should be engaged or involved in this. Because the other thing I didn't tell you was I didn't receive a line item of support to do any of this stuff. So I had to do this with my existing resources. And so what I had to do is go with my staff, meet with my staff by bureau, by division, by different areas, and help them understand where I was trying to get to, and repeat that message multiple times before I ever went outside my walls to try to see if I could enroll anyone else in this project that I thought was so important for the state. The beauty was the staff bought into it, and they threw themselves at this project of carrying this message forward, and rather than being resistant to us now being engaged in clinical medicine activities, they started seeing the reason for it and bought totally into the importance of public health integration into primary care if we're going to actually transform in a meaningful way for the population we serve. So that was a critical first step, and I didn't want to skip that one, and I'm glad now I did not, because without their help and support, we never could have done what we've done statewide. And with that, I'm going to turn the controls over to Dr. Applegate, and then I think we'll get into questions at a later point. Thank you.
Wonderful.